Greetings everybody. We're going to address some congenital heart defects here, and we're going to start out with the non-cyanotic congenital heart defects. So there are two categories of congenital heart defects, congenital heart disorders, CHD, however you want to describe it, and that is non-cyanotic, which involves a left to right shunt, and cyanotic disorders, which involve a right to left shunt. And the direction of the shunt is important, but what's more important is the severity of the disease. And non-cyanotic disorders initially are much less severe than the cyanotic disorders. More often than not, the non-cyanotic disorders are going to be diagnosed in older babies, children, even adults, whereas the cyanotic disorders are diagnosed in infancy. So that's one of the big differences. We're going to focus here on the non-cyanotic disorders. We're also going to do a review of some basic cardiac physiology, both adult and fetal. You have to understand the fetal circulation in order to fully grasp these congenital disorders. And then I'll give you a quick clinical approach to these disorders, and then we'll talk about the three non-cyanotic heart disorders in detail. We'll talk about atrial septal defect, ventricular septal defect, and patent ductus arteriosus. So this is the adult heart circulation, and you've probably seen this diagram before. We've got the vena cava going into the right atrium, separated by the tricuspid valve into the right ventricle. The right ventricle separated into from the pulmonary arteries going into the lungs to get oxygenated, and that's separated by the pulmonic valve. Coming back from the lungs, already oxygenated, we're going through the pulmonary vein into the left atrium, and then into the left ventricle through the bicuspid or mitral valve, and then through the aortic valve into the aorta. We've got these three veins that come off of the arch of the aorta, and those are your right brachiocephalic, left common carotid, and left subclavian. And then this is your descending aorta here. Now, in general, your left heart has a higher pressure than your right heart. Always. Your left heart has a higher pressure than your right heart when you're an adult, when you're developed. So this says adult heart circulation, but really this is non-fetal heart circulation. The pressures are, it's not necessary that you memorize the pressures so much, but this is just to give an illustration of what the pressures are. These are all in millimeters of mercury, and they're divided up into range. So in the atria, you don't have a systolic pressure, and then in the ventricles and in the lung circulation and systemic circulation, you do. The one that I would memorize is the left atrial pressure, because this is your normal pulmonary capillary wedge pressure, which, if it's elevated, that shows you that you've got pulmonary venous hypertension. So this is the one I would remember if you have to remember any of these. But this is just to illustrate that the pressures in the atria are less than the pressures in the ventricle, and also less than the pressures in the lung and systemic circulation, and that in the atria you don't have a systolic pressure. All right, so this is the fetal heart circulation here, and one of the big differences with the fetal heart circulation is that there's an atrial septal defect. But it's not really an atrial septal defect quite yet. It's a normal part of the anatomy of the fetal heart, and that is the foraminal valley. And what the foraminal valley does, it allows blood to move from the right atrium to the left atrium. That's going to be really important. So remember that in the fetal heart, you have a higher pressure in the lungs because the lungs aren't working. They're not supposed to. The baby is in amniotic fluid, so there's no way it can breathe. It's not supposed to use its lungs yet, and so we don't want the blood to go to the lungs, because there's nothing for the blood to do there. There's no oxygen there. And so what this foraminal valley does is it shunts the blood from the right side to the left side. And the same thing for the ductus arteriosus. And it's a passive process because you have a higher pressure on the right side than on the left side. Total opposite of what you have in the matured heart circulation after birth. So here's the movement of blood. So it comes in through the vena cava. It bypasses the lungs both by crossing the foraminal valley from right to left, high pressure to low pressure, and the blood that does not pass the foraminal valley, that does get into the right ventricle, ultimately will go from the right ventricle into the pulmonary circulation, which can cross then again through the ductus arteriosus, which is another important part of the fetal heart. And that moves blood from the initial pulmonary circulation to the aortic circulation. So this is how the blood moves in the fetal heart. You have two ways of getting blood from your right to left heart: the foraminal valley and the ductus arteriosus. All right, how do we approach congenital heart disorders? First off, congenital heart disorders are disorders of heart formation and or morphology. And the symptoms include almost all the time murmur, and then depending on how old the child gets, fatigue, wheezing, pulmonary hypertension, failure to thrive. That's going to be a big one when we talk about the cyanotic heart disorders. And then signs of acute or chronic cyanosis. Acute cyanosis being blue or purple lips, extremities. Chronic cyanosis being clubbing of the fingers. We divide congenital heart defects into two categories, non-cyanotic and cyanotic. We're talking about non-cyanotic heart disorders here. And the non-cyanotic disorders involve movement of blood from the left to the right heart. And that makes perfect sense why it moves from the left to the right heart, because the pressure is higher on the left side of the heart than on the right side of the heart. So it's going to be quite easy for blood to move from left to right. The non-cyanotic disorders are somewhat less severe because you're still getting blood, oxygenated blood, through passed into your aorta. These tend to present during childhood or even during adulthood. Surgery is often but not always needed for these diseases. Now, the cyanotic diseases, which we're not going to talk about here, involve movement of blood from the right heart to the left heart. And these are more severe because we're getting deoxygenated blood mixed in and being sent out to our peripheral circulation. And these are more severe. They tend to present during infancy, almost always during infancy, or early childhood. And surgery is always needed to correct these. The age of the patient is going to give you a big hint on what the congenital heart disorder is. So if this is a newborn, you can almost certainly guarantee yourself that this is a cyanotic heart disorder. If it's a young child, it may be a cyanotic or a non-cyanotic, and if it is cyanotic, we usually know what one it is. And then if it's an adult, it's pretty much always non-cyanotic. And then the symptoms, whether or not there's cyanosis, will also guide your differential. However, the best initial diagnostic test anytime you're suspecting a congenital heart disorder is an echocardiogram. That goes for anything with disorders of morphology. So when we're talking about valvular disorders, echocardiogram tends to be the best initial diagnostic test as well. Now, all patients who are diagnosed with congenital heart disorders, regardless of whether it's cyanotic or non-cyanotic, will need antibiotics before dental procedures, surgical procedures, urologic procedures, any procedure where bacteria could spill into the blood. Now, typically, we give antibiotics before any surgery, but when a patient goes to the dentist, they may not get antibiotics. So that's why we need to tell them to get antibiotics before dental procedures. Okay, so the first one we're going to talk about is an atrial septal defect. An atrial septal defect is simply a hole between the right atrium and left atrium. Now, This is not as severe as what we're going to talk about next, which is a ventricular septal defect. Why is it not as severe? They're both holes in the middle of the heart. This is not as severe because the pressure in the atria are not as high, and the difference in the pressure is not as great. The pressure in the left atrium is 12 millimeters of mercury, approximately. The pressure in the right atrium is approximately 8 millimeters of mercury. So the difference is about 4 millimeters of mercury. That's not a huge gradient in pressure. So you're not going to get a whole heck of a lot of flow from the left to the right side. And so because of that, you don't get a whole lot of mixing going on, and you're not going to get a ton of blood getting sent over to the pulmonary circulation. This means that the atrial septal defects are less of a problem, because the big problem that comes out of the left to right shunts are increased flow to the pulmonary circulation. The pulmonary arteries can only take so much blood, and if you get a ton of flow from the left to the right heart and to the pulmonary arteries, you can eventually cause pulmonary hypertension and something that's known as Eisenmenger syndrome, which is where the pulmonary arteries start to thicken up. And that's a problem. That can lead to cyanosis and reverse the defect. So, but with atrial septal defect, you're not getting a whole lot of flow from left to right, just because the pressures in the atria are not very high. So you'll get a 4 millimeters of mercury pressure gradient, which is going to push blood from the right atrium to the left atrium. So you'll get a little bit more blood moving into the pulmonary arteries, but not as much as what we're going to see with a ventricular septal defect. So blood moving from the left to the right, as with all non-cyanotic defects. You're still getting oxygenated blood going into the aorta, so you're fine there. So this is a congenital non-cyanotic heart defect where the wall between the left and right atria is incompletely closed. And almost always this is a minor defect, and most of the time it's not going to warrant surgical treatment, but sometimes it will. It just depends on the severity. The patient often has a history of frequent colds and productive cough, and the reason for this is that they've got an increased amount of flow, a slightly increased pressure in their pulmonary arteries, and so that can cause a little bit of pulmonary edema, and that makes the patient at risk for catching viral infections, pneumonia, and so forth. So they have these patients tend to get sick more, have pulmonary infections more, etc. So history of frequent colds, productive cough, that's common with ASD. They may or may not have a known history of murmur, but if you do a physical exam, you will hear it. So the symptoms and signs on physical exam, you're going to hear a systolic murmur. And it's a systolic murmur because when is the blood getting pushed across? It's getting pushed across during systole. That systolic murmur is going to be heard best around the left upper sternal border in that area. The thing, though, that really makes this for sure the septal defect is that you have a fixed S2 split. And I don't want to go in too much to what S2 splitting is all about, but basically the reason that you have a split with your S2 normally, and we all have S2 splits, is because when you breathe in and you've got your lungs are expanded, that reduces the pressure in the lungs, and that's going to allow for more blood to move through, and that's going to split the S2. Now, with patients who have atrial septal defects, they're constantly getting more blood moving through their pulmonary valve. So their pulmonary valve is always going to be split during S2. So if you want to know more about the cardiology of the S2 sound, you can go back to the cardiology section. But these patients have a fixed S2 split, systolic murmur and a fixed S2 split. That S2 split, fixed S2 split, is what's going to point you towards the atrial septal defect. As far as diagnosis, like with any congenital heart defect, the best initial diagnostic test is an echocardiogram. And oftentimes, if you're looking at an adult and you hear that systolic murmur, especially up around the left upper sternal border, we do the echocardiogram in particular because we want to rule out the presence of atrial stenosis, which can also give us a systolic murmur in that area. But again, like I've been saying, the S2 split, that's something that really pulls this out and makes this unique on physical exam. Treatment is not necessarily needed. We do treatment based on the presence of symptoms and the patient's wishes. So if desired, you can do closure. This can be done either percutaneously via a catheterization, or it can be done via open surgery. It's pretty much never done by open surgery anymore. It's almost always done percutaneously. So that's the atrial septal defect. Now we're going to contrast this to the ventricular septal defect. The ventricular septal defect is the most common congenital heart defect, and this is a bigger deal because the pressure in the left ventricle is much higher. Pressure in the right ventricle is a little bit higher, but the big difference is that the pressure gradient between the left ventricle and the right ventricle is much higher than the pressure gradient between the left atria and the right atria. So you're going to get a lot more blood shunting from the left to the right side than you did with the atrial defect. So in this case, the pressure of the left ventricle is 128. It's the approximate systolic pressure. And the approximate systolic pressure of the right ventricle is 12 millimeters of mercury. So that's a difference of 116 millimeters of mercury towards the right ventricle. Whereas with the atrial septal defect, you only had 4 millimeters of mercury. So you've got, about 30 times the pressure moving blood towards the right side of the heart. And so that's going to cause a bunch of problems. Namely, the problem that this is going to cause, though, is an increased pulmonary pressure. You're going to get increased pressure in those pulmonary arteries, which is going to result in pulmonary edema, and eventually it's going to result in stenosis of the pulmonary arteries, which can lead to a complication known as Eisenmenger syndrome. So this is, again, a congenital noncyanotic heart defect where the wall between the left and right, in this case ventricles, is incompletely closed. And this is more significant than an atrial septal defect since more blood is shunted across a ventricular septal defect, and more blood is going into the pulmonary circulation. On history, this is typically going to present in infants, not necessarily newborns, but infants, maybe toddlers, and it's going to present as a failure to thrive. And it's not a failure to thrive because they're not getting enough oxygenation or they're not getting enough blood. The failure to thrive, meaning they're not growing properly, usually happens because when they're trying to feed, they have to stop to get oxygen. And that's partially because of the complications with their lungs. And so this failure to thrive is a big part of the ventricular septal defect. And this is one of the things that the pediatrician is going to be noting, and failure to thrive should certainly point you towards a ventricular septal defect. Sometimes the parents will tell you that there's difficulty with feeding, but you can't necessarily rely on that. Symptoms: you'll hear a systolic murmur, heard best around the left upper sternal border. The child will also have tachypnea and sweating. And if you try to elicit it from the parent, they may be able to tell you that the child has sweating when they're trying to feed. That would be a case where, that would be a time where that sweating and tachypnea would be more likely to happen during feeding. Best initial diagnostic test here is an echocardiogram, and then if for some reason a chest x-ray had already been done for one reason or another, like any Noncyanotic heart defect, because you're getting shunting to the right side, more blood to the pulmonary circulation, you would have increased pulmonary markings. So that would be a hint. However, a chest x-ray is not your test for a VSD. Your test for any congenital heart defect is an echocardiogram. And the treatment here is surgical closure. We always do closure for this. Sometimes we can wait, sometimes it closes spontaneously, but the definitive treatment is surgical closure. And a ventricular septal defect is the most common congenital heart defect overall, and that's including the cyanotic defects as well. Okay, patent ductus arteriosus. So now we're not involving the heart in and of itself, we're involving that ductus arteriosus that communicates and is an important portion of the fetal circulation. So the ductus arteriosus is supposed to close during infancy, and it usually does. And remember that ductus arteriosus plays a big role in helping the blood move from the right to the left because we want to bypass the lungs and go right back into the systemic circulation. Now, when the heart develops and when the child takes their first breath and the lungs expand, the pressure in the lungs drop, and so the pressure in the right heart drops, and the pressure in the left heart because any kind of opening between the two ventricles and any kind of possible opening between the two atria, those close. And so your left ventricle, left atria will have a higher pressure. Your right atria, right ventricle have a lower pressure. Just the reverse of the fetal circulation. And so the result of this is not that we're getting a right to left shunt as we did with the fetal circulation across the ductus arteriosus. Rather, because of the pressure gradient, we're going to have a left to right shunt across the ductus arteriosus. So what happens with the patent ductus arteriosus, or also known as a persistent ductus arteriosus, is that we get blood moving from the aorta. This is going to be actually coming from the descending aorta. It's not, I didn't illustrate it here perfectly. It's going to be coming from the descending aorta where the ductus arteriosus comes off to the pulmonary trunk. And then that's going to move oxygenated blood, extra blood, into the pulmonary circulation. Now, what you're going to note here is this classic, constant, machinery-like murmur, and it's heard constantly during systole and diastole. And it's going to be loud enough to where S2 is going to be hard to hear. So when you listen to the child's heart, it's going to sound like this, like machines moving about. And that's why it's called this machinery-like murmur. Typically, this is going to present within the first few days of life. And you'll know it flat on because of this machinery-like murmur. Once you hear it once, you'll never forget it. You should be able to go on YouTube and just type in machinery-like murmur, and you'll be able to hear it. And it's very, very, very unique. The diagnosis here, best initial diagnostic test, is an echocardiogram. What do we do for treatment? So the question first is the child premature? Patent ductus arteriosus is very common in premature children, and the reason is because if the child's premature, they don't have time to get their ductus arteriosus closed. So a lot of times it stays open. If they're premature, then you should try giving them indomethacin first. That's the best initial treatment. However, if the child has signs of congestive heart failure, or if the child is not premature, if they're full-term infant, then you're going to need to do surgical closure. So I would say indomethacin for preemies, for fully developed children, for full-term children, or children who don't respond to indomethacin, you're going to need to do surgical closure. But there is a medical management here that we do need to keep in mind before we jump into recommending surgery.